All right, let's get straight into it. We're executing a rapid-fire clinical mastery explainer targeting the 270-plus scoring tier. No pleasantries today. We are analyzing an integrative mixed block simulation, strictly isolating the high-yield differentials, intricate mechanisms, and discrete management steps you need for absolute diagnostic precision under pressure. Let's get to work.
Module 1, Tick-Borne Hemodynamics and Co-Infections. We must instantly contrast two distinctly different pathophysiologic threats that actually masquerade behind a very similar initial tick exposure. First up is babesiosis. This protozoan, transmitted by the Ixodes tick in the northeast U.S., specifically targets and invades erythrocytes, and that precipitates severe intravascular hemolysis. You've got to look for the classic triad of fever, profound fatigue, and jaundice, which is driven by elevated indirect bilirubin and LDH. Now contrast that with ehrlichiosis. Transmitted by the Amblyomma or Lone Star tick, this bacterium infects monocytes. It drives a systemic inflammatory response that's typically completely devoid of a rash. The strict laboratory signature here: severe leukopenia, profound thrombocytopenia, and elevated transaminases. So it's the hemolytic target versus the leukopenic threat.
This brings us to a crucial clinical axiom. This is an absolute management rule you've got to lock into your memory. Doxycycline completely fails against babesiosis. While doxycycline is the definitive cure for ehrlichiosis, as well as Lyme disease and Rocky Mountain spotted fever, it is entirely ineffective against the Babesia protozoa. Babesiosis strictly requires a regimen of atovaquone and azithromycin. No exceptions.
Let's break down this clinical variance and see how it builds your diagnostic speed. Picture this shared presentation: a patient from the Northeast or Midwest with tick exposure, fever, malaise, and myalgias. Now, what's the divergent variable? If their labs show hemolytic anemia and jaundice, your diagnosis is strictly babesiosis. But if the labs demonstrate severe pancytopenia and transaminitis without hemolysis, you're definitively looking at ehrlichiosis.
Let's test this with an integrated assessment vignette. We've got a splenectomized patient from Massachusetts who develops a fever, dark urine, and scleral icterus following a hiking trip. Look closely at the specific hemodynamic markers presented here. We have an absent spleen, which is a major risk factor for severe, life-threatening disease, and we have signs of profound hemolysis, namely the dark urine and icterus. We need the specific peripheral blood smear finding that confirms the diagnosis.
Let's systematically eliminate the distractors based on exact pathophysiology. Option A, intracytoplasmic morulae in monocytes. That's the definitive marker for ehrlichiosis, which lacks the profound hemolysis we see here. Option B, bipolar standing coccobacilli, describes Yersinia pestis, the plague, which is completely mismatched clinically. Option D, crescent-shaped gametocytes, points to Plasmodium falciparum malaria, highly unlikely in a Massachusetts hiker. Option E, schistocytes with decreased haptoglobin. This indicates a microangiopathic hemolytic anemia, like TTP or HUS, but it just doesn't fit the specific tick exposure infectious prodrome. That leaves option C, the intraerythrocytic Maltese cross or ring-shaped trophozoids. This is the strict diagnostic microsignature confirming babesiosis.
Module 2, Spinal Cord Trauma and Tract Transection.
We've got to strictly contrast these distinct anatomical deficits. Think about central cord syndrome. This is overwhelmingly triggered by a hyperextension mechanism. Think a severe whiplash injury in an elderly patient with pre-existing cervical spondylosis. The damage localizes specifically to the central gray matter and the crossing spinothalamic tracts. This dictates a profound, disproportionate upper extremity motor weakness and a classic cape-like loss of pain and temperature sensation. Lower extremity function remains largely preserved. Contrast this directly with a catastrophic flexion injury, anterior cord syndrome. Driven by severe hyperflexion or burst fractures of the vertebral body, this transects the anterior two-thirds of the cord. The result is bilateral flaccid paralysis due to corticospinal damage and loss of pain and temperature due to spinothalamic damage, occurring entirely below the level of the lesion.
Lock this anatomic absolute into your active recall right now. Anterior cord syndrome strictly preserves intact proprioception and vibratory sense. Why? Because the dorsal columns are located in the posterior aspect of the spinal cord, and they are entirely spared in anterior cord injuries.
Utilizing our clinical variance framework again, we can isolate the exact neurological exams required to localize the lesion under intense time pressure. Here's the shared presentation: a trauma patient with acute motor and sensory deficits. The divergent variables? Well, does the exam show disproportionate weakness isolated to the hands and arms? That's definitively central cord syndrome. Does the exam reveal complete bilateral paralysis below the lesion, but with clearly preserved proprioception? That strictly defines anterior cord syndrome.
Time for the vignette. A 70-year-old male presents after a rear-end motor vehicle collision with severe weakness in his bilateral hands and arms, but normal strength in his legs. This demands an exact anatomical localization based purely on the physical exam findings of a classic hyperextension injury. Let's exhaustively tear down these highly competitive options by matching them to their respective syndromes. Option A, anterior 2/3, causes anterior cord syndrome. That presents with bilateral paralysis below the lesion, not isolated arm weakness. Option B, hemisection, defines Brown-Séquard syndrome, presenting with asymmetric deficits like ipsilateral motor loss and contralateral pain and temperature loss. Option D, dorsal columns. That would cause isolated loss of proprioception and vibration, like what we'd see in Tabes dorsalis or vitamin B12 deficiency. Option E, anterior horn cells only, describes lower motor neuron conditions like polio or spinal muscular atrophy, presenting with flaccid paralysis. This perfectly validates option C, the central gray matter and crossing spinothalamic tracts. This is the precise structural etiology of central cord syndrome.
Module 3, Nephrotic Syndrome and Neoplastic Triggers.
Here we must differentiate two major adult proteinuric states. First, focal segmental glomerulosclerosis, or FSGS. You've got to emphasize the distinct secondary viral and toxin triggers precipitating this massive proteinuria, strictly defined as greater than 3.5 grams a day. Look for uncontrolled HIV infection, chronic heroin use, and massive obesity. Next, we shift to membranous nephropathy. While it can be primary, driven by anti-PLA2R antibodies, its secondary form strictly functions as a paraneoplastic syndrome. This paraneoplastic destruction is triggered by solid organ malignancies, like lung, colon, or breast adenocarcinomas, or by chronic hepatitis B infection. You've got to lock in this visual microsignature. When looking at electron microscopy, you'll see the characteristic spike and dome subepithelial immune complex deposits right on the basement membrane. This is the exact morphological confirmation required to cement a diagnosis of membranous nephropathy. But stay highly alert for this hemodynamic trap. All nephrotic syndromes inherently dump antithrombin 3 into the urine, creating a systemic hypercoagulable state. However, membranous nephropathy carries the absolute highest risk for catastrophic renal vein thrombosis. The massive loss of this crucial anticoagulant protein predisposes these specific patients to sudden vascular blockades, which rapidly present as acute flank pain, hematuria, or a left-sided varicocele. Executing our final clinical variance breakdown, we isolate the demographic and systemic variables, separating these identically presenting edematous states. The shared presentation is an adult with massive proteinuria, hypoalbuminemia, and severe edema. The divergent variables, if the history strongly includes HIV, chronic heroin use, or predominantly African American demographics, the diagnosis is FSGS. But if the history links instead to solid tumors, hepatitis B, or acute venous thrombosis, the diagnosis shifts entirely to membranous nephropathy. Here is the ultimate integrated assessment vignette. A 65-year-old male with a new diagnosis of colon cancer develops profound lower extremity edema, frothy urine, and sudden left flank pain. This specific scenario forces you to simultaneously recognize the paraneoplastic nephropathy indicated by the colon cancer, the edema, and the frothy proteinuric urine, and its resulting thrombotic complication, which is the sudden flank pain indicating an acute renal vein thrombosis. Systematically deconstructing the 5 options. Option A, focal glomerular sclerosis, is the hallmark of FSGS, which is totally misaligned with the colon cancer trigger. Option C, linear anti-GBM deposits, defines Goodpasture syndrome. That's a nephritic syndrome presenting with hemoptysis and hematuria, not isolated massive proteinuria. Option D, effacement of foot processes with normal light microscopy, is minimal change disease, predominantly seen in the pediatric population. Option E, nodular glomerulosclerosis, is the definitive finding for long-standing diabetic nephropathy. This perfectly validates option B, granular deposits of IgG and C3 with a spike and dome appearance. This is the definitive pathological finding for secondary membranous nephropathy, driven by his underlying solid organ malignancy. As we wrap up this explainer, I want to leave you with a final, provocative thought. How will mastering these strict comparative matrices alter your clinical decision-making when the variables suddenly diverge? In a high-stakes simulation or out on the ward,
It's your ability to instantly recognize the clinical variance, isolate the precise anatomical lesion, and anticipate the exact hypercoagulable threat that separates an average performance from total clinical mastery. Apply this ruthless differential framework to your upcoming studies, and the correct path is simply going to reveal itself.